So these are some of the basic terminologies of CTOs, what we describe: the proximal cap, the length of the CTO, the distal cap, the distal landing zone, and usable interventional collaterals. A lot depends upon whether we go antegrade or retrograde, depending upon the proximal cap. If it's a tapered cap, it's usually easy to puncture and easy to progress. If it's a blunt cap, it's a bit more tricky. If it's an ambiguous cap, at times it makes it difficult, if not impossible, to proceed antegradely. Another factor is obviously the proximal cap is exposed to systemic pressure. So as time goes on, as it becomes blunt and ambiguous, often there's calcification associated, which also creates a problem with regards to making antegrade progress. Next factor is the length of the CTO, whether we go antegrade or retrograde. It might look there are channels, there might be a trickle of flow, but these channels are not straight lines. And the longer the length of the CTO, less likely that you can have an intra-plaque passage of the wire, and more likely you'll end up going subintimal. So there are various scores which helps us to give an idea whether we can do something with an antegrade wire escalation technique, or we have to consider a dissection reentry or a retrograde approach. And these are 5 factors, and once you cross a JCTO score of 2, it becomes less and less likely that you'll be successful going antegradely. And these are some of the 4 basic techniques which already been alluded to. But this is basically a little schematic. If you can go straight through the plaque, it's antegrade or retrograde wire escalation. If you can't and go subintimally, it's called a dissection reentry. There are multiple algorithms, and algorithms have become more and more difficult and more complex because there are iterations under all of these. But bottom line is, these are the 4 questions we ask. We look at the cap, we look at the distal vessel, we look at whether there are usable interventional collaterals, and whether there is a major side branch close to the distal cap. And if the answer is no to all of them, usually you can do this antegrade. If more of these are yes, you often land up going retrograde. That's in short how we approach with this antegrade or retrograde. So let's talk about strategy and some examples to see how we go through it. So if it's a short CTO with a clear proximal cap, majority of the time we can do this with antegrade wire escalation technique. So some of my videos didn't play. Basically I just went through the slide 3 times, and this slide was working just when I tried it outside. Okay. Fine. I don't think you can solve this because I've gone through this 3 times. If you just let it go, I'll try to see what I can do with this. Majority are still slides to make it easier, hopefully. As for example, this patient has what we would classify as a shortest CTO. Only issue is there is a side branch. So kit usage is very important. Doesn't matter how easy or difficult it looks, because once you land up struggling in what looks like an easy CTO, it just makes it difficult and more likely you're going to fail. So this wire kept going into the side branch, and this is still within the CTO segment, and it's hard for me to turn down. So this is the recross device, which was part of the question. So this patient had 2 CTOs, so I had opened 1 microcatheter, which is the recross. So keeping the recross, using the recross, I used in this occasion as a dual lumen microcatheter, access the main AV circumflex, and this is the final result as far as the circumflex goes. Then move over to the right of the same sitting for the same patient. Length of the CTO probably over 20. There's a major bifurcation close to the distal cap, not at the cap, but pretty close to it. However, there wasn't any easy usable collaterals, and the patient's BMI was 35, which also creates this challenge with visuality when you're doing some complex retrograde cases. So the plan was essentially to try and to get wire escalation, keep an open mind, swap over to parallel wiring, and if that also doesn't work, aim for an ADR, but preferably a last, because so close to the bifurcation, ADR might be a challenge. So this is the first wire passage. As you can see, this is a Gaia 2 wire, which has gone above the PLV branch. So what we do is we keep that in place. Now we use the recross as a parallel wiring kit. Try to the distal side port worked out to be the correct side port. You take a Gaia 3 wire, which is slightly stiffer than the first wire. That's what we usually do for parallel wires. and the wire finds its way into the PLV. Then at the end, we use the recross again as a dual lumen microcatheter to re-access the PDA to make sure we have patents in both the side branches. So this answers some of the questions. I call it a poor man's Stingray, but a very user-friendly one. So just like the Stingray, it has two side ports, and they're 180 degrees to each other. And that's depicted in this picture. It's a 5 French compatible device. It can be delivered over your routine first-line CTO wire. So the wires on which I usually use it are typically the Gaia wires. It's very hard on the fielders, so it's a very deliverable compared to a Stingray, and you can trap it in a 6 French. I'm not saying you do CTOs in a 6 French, but if you get stuck for whatever reason in a difficult non-CTO case, this can be used and you can trap it out. And it offers a fair amount of versatility of how it works. So a second one is a patient, if you have a CTO length of more than 20, you have a clear proximal cap, good landing zone, ADR is an option to when you're going antegradely. So I don't think I need to show this, but when the Stingray and Crossbows came out, I think we used it in a fair amount of cases, which probably we could have done without, but probably it was part of the learning curve. So this is not the most difficult CTO, but this is where we used a short knuckle, then a crossboss, then went forward and punctured with using the Stingray and the Stingray wire. If I'm redoing a similar anatomy now, I will be using it very likely with Antegrade wire escalation or a parallel wire. I don't think I'll need a Stingray for something which is not as or relatively simple like this one. A slightly more complex ADR, if you could say. This is a post-bypass patient. The collaterals are much more tricky, quite prominent bridging collaterals. Not entirely sure the course of the artery, where it is. You sort of have an idea where the cap is, but you are not entirely sure. And it seems there's a degree of tortuosity in the CTO segment from how the collaterals have gone. But there wasn't any usable retrograde option. So the plan here was Antegrade and very likely ADR, best scenario, hope for a last. So it was, the first bit was a bit of luck. The cyan wire just slipped into what would be the CTO segment. So that solved the problem of the cap ambiguity. Then moved over to a slightly stiffer polymer jacketed wire, which is the radar wire, but unfortunately, but not unexpectedly, it went subintimal just beyond the distal cap. So what we did at this point, we took a small balloon to make a little track in the CTO segment, proceeded the recross device, which you can see, which is arrowed just beyond the distal cap. The side port, the middle side port, or the distal side port, was on the wrong side. So we had to pull back the radar wire, take a CP12, and puncture through the proximal side port into the distal true lumen. And this was the final picture for the RCA. Okay, so when do we go retrograde? I mean, when it becomes more and more complex, you're not sure of the cap, it's a long CTO, there's diffuse distal disease close to the cap is close to a major bifurcation, and obviously there has to be usable collaterals. So this is a patient who presented with a lateral end STEMI, had a hazy lesion in the intermediate which was fixed, but had a dominant RCA which was felt with the bystander. So he came to clinic but still had a lot of symptoms. Anyway, this again, okay, this plays up, okay, this is not playing, but if I could just verbalize what we had. So we had a proximal cap which was clear but appeared pretty calcific. We had a very long length of CTO which was around 60 millimeters, but definitely over 40. The body was calcific. There was a bend towards the end of the RCA, which made it a bit more challenging as well, but we had a very usable septal collateral. So the options was a difficult ADR, but delivering the kit in the distal part of the RCA would have been a challenge. And second option was retrograde. So in this patient, we went retrograde. Did a base at the top end and traversed the body with the combination of wire escalation and then dissection re-entry. So in these complex patients, you have definitely done a on subintimal. It's always recommended you image it. And the reason it is good to know where exactly you are subintimal. So in this picture, for example, it tells you where you are subintimal, where you go subintimal. And the reason is if you land up having a D-shaped stent in the subintima, if you land up post-dilating it aggressively, you can have a big perforation. So knowing exactly where you are, where you can start placing your stents and where you can finish placing your stents is important. So this is, again, relevant to one of the questions asked. So if you do the subintimal stenting, what do the vessels heal? The answer is they do. So this is the subintimal area where the stent was subintimally. Is absolutely nicely healed. If you just see this OCT, you wouldn't know the stents are all subintimally in place. So they do heal up over time. This patient, for example, significant LV dysfunction, again a long length of CTO, but a straight usable epicardial collateral. You very rarely get as straight as that from the circumflex. So because of these factors, the plan was to go primary antegrade, primary retrograde, and let the wire run. If the wire runs smoothly, then retrograde wire escalation. If it has problems, you do an RGR. So this, in fact, the whole procedure was done with the straight wire technique, largely retrograde. You can see the acute marginal is patent. What is important when you use the septal collaterals is this is the retrograde wire which has been pushed forward, and you take a safety shot just to make sure you have not got a perforation of the epicardial. Because if that's the case, you would need to coil it from both ends. So before you take the retrograde system out or retrograde wire out, this is a safety step. This is another patient who was an inpatient, in fact, what we thought was a type 2 MI, but clearly had inferior changes and essentially had a non-sustained VT on ETT and had this angiogram. So we thought we can do this antegradely, but we clearly had no idea where we were going, but definitely not in the right place. So we quickly moved over. It was a 6-French system because I was quite confident that we'll be able to do it antegrade, but it didn't happen. So this is a real-time wiring of the apical epicardial collateral from the left system with the 6-French guiding system. And when we then came towards the distal cap and let the Gaia 2 run, it basically told us that we were entirely in the subintimal space with the antegrade system from the very beginning. So if we had carried on, we would have just propagated the hematoma in this particular patient. Subtle changes can make a big difference. For example, this is a patient with an ambiguous cap proximally. So this is an IVUS place where we thought we could see the cap, and then I take 2 projections. Successfully do this with a puncture. But if it's slightly different with a small branch at the top end, it basically can make a big difference to whether you can pass your wire forward or not. So this one we had to go through the whole algorithm and finish off. So I'm just going to go to my conclusion slides here. Yeah, so this is just one slide I'll touch on. So this is a very recent publication which essentially shows the techniques being used. As time has passed on, we have more and more success with antegrade wire escalation and a reduction of antegrade dissection reentry. And the retrograde has remained stable. So, we have got better with the kit, especially with the antegrade wire techniques. And this is despite us having increasing success with, relatively lower complications. To summarize, I feel there's no universal approach of tackling a CTO lesion. And at times you need a combination of approaches for an individual patient. Usually, the planning is dictated by the anatomy. If it is thought to be that antegrade has a fair chance of success, it's worth trying it as a first approach because it has lower complication rate. What really influences is the familiarity and expertise of each operator, how you take on a case. So if you feel a particular patient requires the type of approach which is beyond your current expertise, is worth working with a senior colleague or an proctor for that. Thank you.